Hello, my name is Ben Wessler. I'm a cardiologist in the United States. I work at Tufts Medical Center in Boston. I'm excited to present our abstract today, Clinical Prediction Models for Patients with Acute Coronary Syndromes, Results from Independent External Validations. Increasingly, it is recognized that predictive models often do not perform as expected when they are tested on new databases. As a result, independent external validations of predictive models are recommended. Unfortunately, they are not often performed. Here, we conduct a series of fully independent external validations of predictive models for patients with acute coronary syndrome. Very briefly, we conducted a systematic review to identify predictive models for patients with acute coronary syndrome, and then also identified validation databases. These databases come from clinical trials that are publicly available and allow us to assess the performance of the published models in new settings. We conducted fully independent external validations using these 5 clinical trial databases and assessed model performance with respect to discrimination and calibration and net benefit, both with and without recalibration techniques. We identified a total of 269 predictive models, of which only 23, or 8.5%, were compatible with the validation databases. In sum, we had 28 clinically appropriate external validations. The median C-statistic of the CPMs in the derivation cohorts was 0.76, and the median C-statistic in the external validation datasets was 0.70, representing a 24% decrement in discrimination. We used the model-based C-statistic to understand whether or not this drop in performance was related most to model invalidity or instead to changes in case mix between these databases. And what we found is that the majority of the decrement was actually due to changes in case mix, not changes in model validity. The median calibration slope in external validations was 0.84, and the median error standardized to the outcome rate was approximately 40%. On the left here is a figure showing each of the independent external validations. This top grouping represents validations that were designated as closely matched when looking at the populations between the derivation and the validation datasets. And below, in red, are the validations done on distantly related datasets, where there were major clinical differences between the patients studied in the derivation dataset and patients studied in the validation dataset. The table on the right here shows the results of the decision curve analysis, and in particular, assessment of net benefit across different thresholds. Thresholds of the prevalence of the disease outcome, half the prevalence, and double the prevalence. And what we see for the original model as published, there's approximately a 1 in 4 or 1 in 3 chance when you are far from the outcome prevalence that there will be net harm applying the given model without any recalibration. Net harm can be guarded against if the decision threshold is at the outcome prevalence, or if there is re-estimation of the coefficients with respect to model recalibration. It is only after recalibration is performed that you can be reasonably confident to guard against net harm caused by these models. In summary, independent external validations of these published acute coronary syndrome predictive models demonstrate that models tested had relatively well-preserved discrimination, but poor calibration when externally validated, and that applying off-the-shelf predictive models often risks net harm unless models are recalibrated to the populations on which they're used. Thank you very much.